Can we rewrite trauma in our brains by taking a different look? Today on the podcast. Welcome to the Licensure Lifeline podcast, the place where you can get the information you need to pass those tests toward being a counselor. In today's episode, we are going to look at EMDR, eye movement desensitization and reprocessing. Before we dive into that topic, really quick, you can find us on Instagram where I post flashcards and other little tips and tricks to help you study better and pass the test. I'm also happy to announce that I will be opening up my own private practice, which I'm really excited about. It's a bit of a dream come true after years and years working in group practices. I'm finally going solo. This will not impact the podcast too much. In the past, I've tried to do 1-2 shows a week with this podcast, but instead I'm only going to be doing one show for this podcast and actually starting a new podcast for my private practice. This podcast will be called The Urban Alchemist, which is the same name as my private practice. It's going to focus around health, wellness, just well-being in general, really aligning people's lives, helping people align their lives better with the things that they want. The first episode's actually already up. It's a part 1 of a 2-part series around my experience utilizing GLP-1 medications. If you're interested, go take a listen. Okay, let's get into EMDR. The origins of EMDR go back into the 80s. Psychologist Francine Shapiro was taking a walk when she noticed something peculiar. As her eyes moved back and forth while thinking about distressing memories, she felt those memories and their emotional intensities to a pretty significant degree, almost as if she was within that moment of those intense feelings. So, as any good clinician does, she began to study this phenomenon, and she systematically took a look at, how and why this was occurring when she was thinking of these thoughts, when she was having these thoughts, and published her findings in 1989, showing that EMDR is effective in reducing symptoms of post-traumatic stress disorder. When I started school, everybody wanted to go back and get a EMDR certification once we graduated. It was seen and still is seen as a great way to support individuals that struggle with trauma, especially when I was working in the eating disorder space. I saw a lot of individuals that were doing regular eating disorder counseling while also seeing a clinician and getting EMDR treatment weekly. From EMDR, Shapiro went and also developed adaptive information processing. The adaptive information processing model, which provides the theoretical foundation for EMDR. The AIP model posits that trauma disrupts the brain's ability to process and integrate information, leaving memories stuck in a raw and emotionally charged state. EMDR's structured approach helps process these memories, allowing clients to heal. So, what does this actually look like in therapy? This is actually an 8-phase protocol that people go through when doing EMDR. First is the intake history. The therapist gathers the client's history and identifies target memories to work on. From there, there's a bit of a preparation phase. Building trust is key here. Therapists explain EMDR, answer questions, and ensure the client feels safe. Next is the assessment. The client identifies the most distressing aspects of the memory, including negative beliefs and physical sensations. From here, you go into the magic phase, the desensitization. This is where the therapist, the clinician, will use bilateral stimulation, like eye movement or tapping, to reduce emotional distress. I've seen people use little lights that go back and forth, and the idea here is your eyes actually follow the bilateral stimulation. They go back and forth, back and forth. Next is installation. The therapist helps the client to replace negative beliefs with positive and adaptive beliefs. From here, the clinician will do a body scan where physical sensations tied to the memories are addressed. Next, you have closure. The therapist ensures the client feels grounded before the session ends. And then there is also a reevaluation phase where progress is assessed as the EMDR takes place. On average, people do about anywhere from like 6 to 12 sessions of EMDR. So it is a bit of a process. If you can imagine going weekly, several months worth of work to really address trauma. You can also imagine how powerful this would be incorporated to regular therapeutic sessions where you're also addressing that trauma. I have seen people, which I do not recommend, do both a therapy session and an EMDR session on the same day. That is a lot of stuff to come up in the same day. If you have somebody that you're working with and they're interested in doing EMDR, you're interested in doing EMDR on your own, I would highly recommend doing it separate days of the week if you're also doing therapy along with it. In therapy, EMDR is primarily used to address PTSD. I've seen it used with wartime PTSD. I've seen it used with assault. Also, I've seen it used for things like anxiety and phobias. If you think about what EMDR is doing, you're desensitizing the individual, having them go through these traumas, having them kind of remember some of these things over and over again and getting them desensitized to this. So this also helps with anxieties and phobias as well. Grief and loss, if you especially like think about how traumatic losing somebody that you care dearly about can be. So this is another place where you can provide support for the individual. Chronic pain. I've also seen EMDR help with chronic pain, as well as addiction, where you really explore and resolve trauma that contributed to a substance use. Let's go over some of the benefits and limitations of EMDR. First off, the benefits. Nonverbal processing. This is ideal for clients who find it difficult to talk about their trauma. It's evidence-based, supported by organizations like the APA and the VA for treating PTSD, and it's efficient. Many clients experience significant relief in just a few sessions. I mean, like I said, on average, 6 to 10 sessions. This is actually pretty efficient for working with somebody, especially somebody that's dealing with dealing with something that's just so significant. The limitations for EMDR, not everybody, especially those who are currently unstable or disassociative, respond well to EMDR. You really do have to do an evaluation to see if the person is in the right place to do EMDR before they do it. And it does require special training. You're going to see this as you become when you become a therapist. There are pretty significant price tags for a lot of these trainings and certifications. It seems like there's always something in my inbox where somebody wants another couple $1,000 for me to get certified in something. So keep that in mind. It is an investment, but it can very much so be worth it and very fulfilling. Here's some books that might be nice for you to take a look at if you're interested in EMDR. First book is going to be Eye Movement Desensitization and Reprocessing. I know, pretty wild title. But it's just basic principles here, protocols, procedures. This is actually by Francine Shapiro. And then Tapping In is another one by Laurel Parnell. You can also find out more on the EMDR International Association website, www.emdria.org. This is where you're going to find like trainings and research about EMDR. Okay, let's go over some questions. First question, who developed EMDR? Is it A, Aaron Beck, B, Francine Shapiro, C, Mary Ainsworth, or D, Carl Rogers? Easy one here. B, Francine Shapiro. Question number 2. Which phase of EMDR involves strengthening positive beliefs about traumatic memories? Is it A, assessment, B, installation, C, body scan, or D, closure? Answer here is going to be B, installation. Question 3. What is a key feature that differentiates EMDR from other therapies? Is it A, cognitive restructuring, B, bilateral stimulation, C, exposure techniques, or D, the use of homework? The answer here is going to be B, bilateral stimulation. Question number 4. Which model underpins the theoretical framework of EMDR? Is it A, adaptive information processing model, B, cognitive behavioral model, C, systems theory, or D, psychoanalytic model? Answer here is going to be A, adaptive information processing model, API. Last question. EMDR has been shown to be particularly effective for A, bipolar disorder, B, PTSD, C, schizophrenia, or D, generalized anxiety disorder. Answer here is going to be B, PTSD. All right, folks, that is going to be it for today's episode. I hope you found this helpful. As always, keep on studying.